So let me go into the slide. I'm not going to go into big detail. I got to share the screen first. Let me share. So what we're talking about today, everything that we talk about today will be evidence-based, of course. And today it should have been, the lead slide was hypertension, heart attack, prostate cancer, BPH, benign prostatic hypertrophy, UTI, urinary tract infection, and urinary incontinence, especially in the female population. So we want to make sure that we cover that as well. And this is all evidence-based. About every 2 to 3 months, I update the literature, make sure everything is current. And again, if you guys have any questions, please feel free to ask. We've talked about hypertension before. Some of you have not been on the Zoom before, the webinar before, so you have not heard this. I'll be very brief with this part of it. So hypertension, again, it's a silent killer. Why is it a silent killer? Because typically, you don't know you can get a stroke, but you get a stroke. You have a heart attack, but you have a heart attack. And that's because your blood pressure is typically out of control, right? It is definitely the number one killer. One of the number one killers, actually. One of the leading causes of death, of course, is cardiovascular disease, which is number one. And of course, what leads to a lot of that is going to be hypertension. I always say there's a myth say that the blood pressure is normal at 120 over 80. A normal blood pressure basically is what you normally run when you're quote normal. How do you feel? If your blood pressure typically runs 100 over 60 and you feel great, you're not dizzy, you don't have any shortness of breath, you have no headaches, nothing like that, no visual problems, and it probably tells me that's your normal pressure is 100 over 60. So if you come to the emergency department, be seen by someone else, your blood pressure is 120 over 80, your pressure is up a little bit, right? So the numbers, that's just a general number. It's like you take 100 people, out of 100 people, 51 of those people have a blood pressure right around 120 over 80. So therefore, they create a norm for that. What are the dietary controls? A lot of dietary controls. The main one that we've talked about is salt and getting those fatty things out of your body. And usually that's when Dr. Gavin usually steps in and say a few words, but we'll see if he wants to say something. Doc, feel free to talk. How to treat blood pressure. Next slide, please. There's a number of ways to treat it. Like I always say, the best treatment, if you don't treat it, of course, you have consequences. So you are what you eat. And again, we said salt is a big culprit of using a lot of the issues that we have going forward. If you can work out about 30 to 40 minutes, about 3 to 4 times a week, that doesn't mean that you have to, like my son, he works out, he buffs out, so on and so forth. But just walking, be briskly, it could be a slow walk, but as long as you get your exercise in, be just stationary. Just, moving your legs in place. They have these nice things out now that you can put your feet in them. You can just roll them, like it keeps your circulation going. That's still an exercise too. You want to develop also a good weight plan and stick with it. Like I said before, some of you know, I used to be a pretty large guy, 265, and that's 2.5 years ago, but I've been on Manjaro as well as lowering my carb intakes. And I've gotten down now. I was disappointed that I'm only at 204, trying to get down to like 185. So, and I started this 2.5 years ago. So it's a journey. So this thing is a journey. The other thing is stop smoking. I always say cigarettes, but what I really mean is stop smoking everything. I mean cigars too. And for me to say that, hey, sometimes for you to go to practice what you preach, hey, it is what it is for me. Taking medications as directed. All too often, a lot of patients stop taking their medication because guess what? Especially men, because there's a libido issue there, right? And Dr. Khan can talk about some of those libido issues as women bring it up. Now, this is funny. What I've noticed is that when the women bring things up about ED and all the other issues that men have, they're more apt to bring it up than the men. So I've had one of these that we did about maybe a year or so ago, and it was almost a big heated discussion because the guy did not want to have everybody on the Zoom, on the webinar, to know he had a problem with his plumbing, put it that way, right? So there was a heated discussion. So we decided not to bring it up. But if the women bring it up and the husband's on, and he just afraid to bring it up, you can have to talk about those issues too. So the other thing is, like I said before, men are not as compliant as females because, again, men tend to get with certain drugs, and unfortunately, these are common drugs that are used in Black males, uh, amlodipine, you name it. They tend to have a Losartan, they tend to have some issues with their libido. But you need to talk to a doctor about making some changes on that. And I want Dr. Gavin to make a comment about healthy eating because he's into the healthy eating part of it. Dr. Gavin is an expert in chronic disease, so he could talk about any of these slides really. So Dr. Gavin, could you just put in something about healthy eating and how you normally explain that?
Well, I won't go into a great deal of detail. You've shown here a fair amount of information on the types of food that are listed under the category of healthy eating. I would simply say this, in this overall discussion about how do you prevent the kinds of things that we are talking about today, heart attacks, strokes, cancers, and other chronic diseases that Dr. Khan will talk about. If you look at all of the preventive strategies for any of these conditions, they start with the same recommendation: healthy eating, physical activity or exercise, stop smoking, and avoid certain kinds of things in excess, like alcohol or even things like processed food. So the key to healthy eating is look at foods that have not been modified from their normal or natural form. And then there's plenty of literature on this. This is one of these things where you can consult with Dr. Google and find out a lot of helpful information. And without going into further detail than that, um, two things: less than you're doing now. Overeating is the key to stop. That's the key thing to stop. Okay, and then healthy eating right on top of that. That's all I would say about that.
Thanks, Doc. All right. So then the different medications that we use for hypertension, and if you've been seeing this, I like to look at redundancy as being really pretty good actually, because each time you're going to retain something a little bit more than that. I'm going to suffice to say this. The literature has shown that for people of color, the first line treatment for us, people of color, that African Americans, Hispanic, Asians, Jamaicans, you name it, the first line for therapy, and we see this in the ER a lot, the emergency department a lot, is a first line diuretic. And what I like to use for a diuretic is typically going to be one of the thiazide diuretics. It's going to either be HCTZ, hydrochlorothiazide, or it'll be hydrochlorothalidone. But you need to have a diuretic usually, and we start them out on that first. So when I see people here, like at the event here today, the fair today, I've written a number of prescriptions for just a diuretic. Get them started with that first. Then we can always work them up to other things that we add, such as the calcium channel blockers. I'm a big fan of calcium channel blockers. Used to be a big fan of beta blockers, but calcium channel blockers seem to work best for Black folk. And you can Google this stuff too, guys, to find out what medication works best for me as a person of color. And guess what? Dr. Gavin mentioned Dr. Google give you a lot of information. Other thing, speaking about Dr. Google, before you go see your doc, Google what your symptoms are, Google what you're being told when you're told it, and make sure that you're able to, I say verify that. We trust, but we verify, right? So the other thing I like to use is amlodipine. I think it's good. And to me, I think that's one of the mainstays for me when I treat hypertension. Now, I got to confess one thing, and I think I did this before. My cardiologist, I have electrophysiologist, cardiologist from Mount Sinai over there in off the beach here in Miami. He's a big believer still in a atenolol, tenoritic. But again, this guy, he's a very super specialist. He's an electrophysiologist with the heart. And for me, for the last 35 years, 40 years, I've been on atenolol. Actually, it's called tenoritic. Tenoritic is a beta blocker, atenolol, plus a hydrochlorothalidone, right? A diuretic. So that's a combination that I'm on. For me, it works well. When I prescribe medication for patients, I do not use atenolol. That's almost like a relic. But if it works for you and you've been on it for years, my blood pressure, by the way, guys, typically run about 110, maybe 118, over 76, something like that. And I feel really good, right? So you want to make sure that you're taking the medication. Now, I did have an issue initially when I first tried with a Tylenol with libido, but sometimes your body will adjust to that. If it does not adjust to it, then I would recommend again that you talk to your primary care doctor, whomever the doctor puts you on the medication, to look for other alternatives than what you're getting. So I'm just going to talk about just those two. To me, those are important. But understand the class of medications. CCBs, calcium channel blockers, are good for people of color, typically for sure. The other thing that you remember are thiazide diuretics. Those diuretics are typically things like ACTZ, hydrochlorothiazide, and hydrochlorothalidone. I happen to like chlorothalidone better because it's a bit more powerful. I get more diuresis than I do when I take the ACTZ, right? Now, when is the best time to take the medication? Listen, it's real careful. The best time to take it, the doctor's really honest, is going to tell you to take it at night. Because that's when your kidneys are functioning well. And I'm sure Dr. Khan can speak to that, but your kidneys kind of work really well when it's resting, when it's at night. The problem is that it keeps you up. You may get up to have a massive urination, maybe twice during the course of the night. So it's probably not going to be best for your sleep. But if you really want to get serious about bringing your pressure down, you're on a diuretic. Again, the kidney concentrates. Why did you think when you first get up in the morning that your urine is typically a little more yellow, right? Because it's concentrated, it's working hard, it's doing its job. Throughout the course of the day, as you take it in that half an ounce of water per each pound you weigh, so if you weigh 200 pounds, it's easy. You should be drinking 100 ounces of water a day. If you weigh only 100 pounds, you should be drinking 50 ounces of water a day. That's how it works out. So you got to keep those kidneys flushed out and keep them moving, because we don't want you to come into this thing called chronic kidney disease. And I would say probably, Dr. Gavin, probably stage 3 or 4. I found out I was a stage 1. Stage 1? I have a GFR of like 89. I thought that was great. Well, apparently it used to be. They've taken away for African Americans. You know, we had a lower GFR that we could qualify for that made us so normal. And I was shocked. In fact, I got upset with my endocrinologist when he told me that, you know, I was a chronic disease stage 1. What do you mean I'm chronic disease? I don't have that. So I got a little upset about that. I want to get into Dr. Strokes. We talked about that before. I can always come back to that later. I want to get Dr. Khan involved in this. Here we go. So prostate gland.
Okay. Well, first of all, Dwight, thanks for having me on here. This is a commendable thing we're doing. We're doctors first, and we like to treat our patients, make them better. But we're also educators, we're teachers. And one of our jobs is to inform our patients and families. Today, I'm going to spend a little bit of time talking about the prostate gland. And the thing that affects us guys as we get older, mostly of concern, is prostate cancer. As you can see from that diagram, the prostate sits underneath the bladder and it wraps around the urethra. It typically is a small gland about the size of a kiwi fruit or golf ball. But for some men, the prostate does grow and get huge as we get older. That condition is called BPH, benign prostatic hypertrophy, which can lead to difficulty passing urine and emptying the bladder, and sometimes require catheters being placed in the bladder and surgeries to relieve that. Today, we're going to spend most of the time, at least in my part, talking about prostate cancer. Why is it important? Prostate cancer is important because it is the most common cancer that affects human beings. It's more common than breast cancer. BPH is a condition of older men. It's caused by the hormone changes that take place as we get older. I mentioned that it causes difficulty in urinating, getting up at night to urinate, weak stream, having to strain to urinate. It is pretty easy to treat with medication, and most men respond well. The drugs that we use are drugs that relax the prostate, and when needed for large prostates, we also use drugs to shrink the prostate. So what is prostate cancer? It's a development of a malignancy in the prostate. And the good news for most of us guys is that although common, prostate cancer is not the killer cancer like pancreatic cancer, lung cancer, liver cancer, or bladder cancer. Prostate cancer has become a condition like diabetes. It's a chronic condition. Why? Because nowadays very few people should die because of prostate cancer. We are able to manage even the most late stages of prostate cancer. So let's talk a little bit about who is at risk for getting prostate cancer and who needs to be screened. The answer to the first question is that we are all at risk, being men, but Afro-American men and men with a family history of prostate cancer, men with a family history of breast cancer and colon cancer are at risk for getting prostate cancer. So we typically would start to screen most men without risk for prostate cancer at age 50. And those patients need to have digital prostate exams and a blood test. We'll get to that in a second. Causes of prostate cancer. Several different theories are out there. Most importantly is the genetic line. I mentioned that there are some men whose family history is very significant. It's not uncommon to find it in fathers, brothers, uncles. We mentioned some other types of cancers like breast that predispose men to having prostate cancer because of a particular gene, which is called the BRCA gene. So when you're at risk for having prostate cancer, you need to be screened more often, and you need to be screened at a younger age. We recommend, with a very positive family history, such as guys with fathers and brothers, that they be screened as early as 40. Others, age 45. Now, the screening for prostate cancer involves this blood test that you're seeing on the screen called the PSA, which stands for prostate-specific antigen. This is a protein produced by the prostate, and it gets into the bloodstream. Women do not have prostates, so they would have a PSA of 0. So if you go into the doctor, which you should at least once a year, you should have that blood test and you should have the digital examination. Who needs to be treated for prostate cancer? Not everyone who has prostate cancer needs treatment, because a lot of men will develop what we call low-grade prostate cancer. And typically that cancer, we can live with it, and it won't cause us to live less or shorter, because typically those types of cancers do not metastasize. The types that need to be treated are referred to as high-grade prostate cancers. They are more aggressive. And the treatment really depends on the age of the patient, health of the patient, and so forth. A lot of different types of treatments nowadays. We mentioned earlier in one of the slides that robotic prostatectomy is a very common new technique for removing the prostate without opening the patient.
Can I ask you questions, Paul, if you don't mind?
Sure.
Yeah, you mentioned something that was very, very key. And I don't know if everybody caught that or not, but it reminds me of Joe Eggleston, a good friend of ours and the patient of yours that you had. Joe used to say to me, all cancer is not death, right? You mentioned about the prostate, and that all these cancers of the prostate do not necessarily need to have surgery. Could you speak about that a little bit more? Because I think that may have gone over
Sure.
people, but what I'm saying is because this being recorded, so they can play this back. But it's important for them to understand that, because when they get a diagnosis of prostate cancer, they think right away, radical prostatectomy, So explain that, because a lot of cancers, as you just mentioned, do not need to have surgery.
Right. So first thing is, if we diagnose this disease in a patient, first question we're asking ourselves, is this cancer likely to affect this patient's lifespan? So if you have a 75-year-old male, he's got a small amount of non-aggressive cancer, he needs to be monitored. He does not need to be treated. On the other hand, if you have a 55-year-old who's got the same type of low-grade cancer, but this guy's got a 30-year life survival, you can't leave that cancer in his prostate. He needs to be treated, even though he has low-grade disease. And it goes to saying that if you have high-grade disease, which is an aggressive tumor, no matter the age of the patient, they need to be treated because those cancers spread quickly and metastasize. So the Gleason grading of these prostate cancers is very important. But just to break it down, we try to keep it simple for patients and tell them, look, you have low-grade disease. This is very slow growing. You can watch this for a while if you want. Or the patient might have a more aggressive form of prostate cancer, and we're going to institute some kind of treatment, whether it be surgery or radiation, or nowadays we're using something that's very popular. It's called focal cryosurgery, which if the patient has a small cancer in their prostate, you can go in there and freeze that area of the prostate without removing the whole prostate. Now, taking out the whole prostate is a big deal for most guys. Number one, after that operation, a lot of them are going to have to deal with erectile dysfunction, and some of them with urinary incontinence. And that might sound simple, but you don't want to turn somebody's life upside down if they have a tumor in there that's not that bad. So we reserve those kinds of surgeries for the very aggressive forms of prostate cancer. Radiation treatment is available, and we use that mostly in the older age group, guys that are over 75, because they have less than a 15-year life survival. And if you radiate those patients, most of them are going to do well for 15 years. I mentioned the cryosurgery, and I'll briefly talk about men who present to our office with end-stage prostate cancer, stage 4. Who are these patients?
Well, what it means, Paul, by stage 4?
Stage 4 would be the final stage, where the tumor has spread beyond the prostate into the patient's bones, liver, or lungs, or brain. So they're metastatic, and that's what we call stage 4. Now, thank God we don't see as much of this as we used to 10, 20 years ago. Why? Because people are told you need to go to the doctor, get your PSA checked, and we are, because of that, capable of diagnosing prostate cancer in its early stages. So very, very few patients present to us nowadays with this stage 4, but we still see it. Even those patients who are at stage 4 have excellent choices for treatment, and we can keep those patients alive for years and years. And that's why I said prostate cancer has become a chronic disease like diabetes. We manage it with different drugs, chemotherapies, immunotherapies, gene-altering drugs. So everybody, no matter your stage, you can be treated and you can be kept alive for a long time.
Yeah, I think, Paul, this is so good that you're discussing this, because a lot of us men, we don't want to go get the bad news. So therefore, we wait, and we wait. And by the time we get to see a person like you, we're probably in stage 4, right? So the idea is that as soon as you begin to feel that you have some changes in either your urinary, I guess, movements, and not movements, but I guess the stream of your urine. You can wake up a lot to go to the bathroom at night. You feel that you empty your bladder, but not quite empty. You begin to get those kind of issues, I would think, that you want to really jump into stuff quickly. And Dr. Khan, you cannot say it enough. I love how you're explaining that. Eloquently explained, easy to understand it. But sometimes we men have to hear this thing over. The women know that's on this call, right? They know that we men got to hear this thing over and over and over again. So as you've been repeating this, I always say redundancy in education. Repeating things in education is very important, because they will eventually get it. Remember, I said they're going to be getting this, the whole webinar that's recorded, and they'll be able to hear you say it over and over again, because some people feel they got a problem. They go to their doc, told they have prostate cancer. Now, unfortunately, a lot of docs, I'd say probably the vast majority of the docs, Paul, they're not like you. They're not like me. They're not like Dr. Gavin and other doctors that we have. They'll tell you, and it's like, it is what it is. Okay. They're very abrupt. I recall going to see with my dad, of course, and my good friend Josephus, he don't mind, he's dead and a good person. But it's the time that you put in with seeing each and one of your patients. And to me, I really always want to thank you. I think you before for it. I thank you here with our group. But it's so important to have a physician they can feel comfortable with and talking with. I tell them this also. If the doctor cannot do a rectal examination on you, you probably don't need to be in the doctor's office, whether it's going to be for prostate issue or maybe colorectal cancer. Rectal has to be done. But I tell them also, get that PSA done before they tickle that prostate. Maybe you want to tell them why that's all done.
Let me just say this also, Dwight, we need to be thankful to our wives and the women in our lives.
100%.
Because I can't tell you how many times I get a new patient coming in. First question, how can I help you? You know the answer. My wife said I need to come here. Well, why did she send you here? They look out for us and we need to tell them how appreciative we are of that.
Great.
Because if left up to us, the majority of us wouldn't go into the doctor to get checked. And I get that.
Yep. All right. The thing that's there also, guys, and you'll have it when you get your actual copy of this. You have some codes there. You have some websites, and the one website there was just a very good one. I looked into that. I can't do it now, unfortunately, because I don't have control of this thing. But that means that the Prostate Cancer Foundation, and it's a group of men, and they form this humongous organization. It must be almost 1 million men that are in this organization. And they share their stories with each other. It's nothing like having people that you can share a story with, because you learn from that. You continue to drive through with the process with that. The other is typically for all cancer in general, but the number one that I'm looking at, that men should look at, and women too, that's with their significant other, is that PCF, www.pcf.org. Again, that's for Prostate Cancer Foundation.
Okay. What is a urinary tract infection? A UTI is a bacterial infection involving the bladder. Now, typically more common in women than in men, but men do get it. We don't call it UTIs in men. We call it more prostatitis, but the concept is the same. Bacteria gets introduced into the urinary tract. Now, in the female, those bacteria come from the vaginal area. And we should all understand the vagina is lined by skin, and all skin in the human body has bacteria. In the vagina, those bacteria serve a purpose. They live in harmony with yeast or fungi and with other bacteria. They all are there to control the pH or the acidity of the vagina. Anything that disturbs that bacterial flora or the bacterial content affects the pH of the vagina. And one of those organisms, because of that, will tend to reproduce more quickly. The commonest bacteria is E. coli. E. coli lives in all our gut. And in women, it is one of the commonest bacteria that form the flora of the vagina. So why do women get urinary tract infections? Anything that interferes with that pH balance in the vagina is going to allow E. coli or bacteria like E. coli to reproduce more quickly. And typically what happens is those bacteria get up into the urethra and then into the bladder and cause cystitis. So when does this usually happen? It can happen during sexual activity where the trauma from intercourse introduces the bacteria from the vagina into the urethra. So a lot of women who are sexually active get these cystitis episodes following intercourse. Another common group of ladies that get these are women who are perimenopausal or postmenopausal. So what happens is that the estrogen content in the bacteria, which also has to do with the pH, gets lowered. The pH changes and bacteria start to grow in there. So perimenopausal and postmenopausal women frequently get UTIs, and very easy to treat by restoring the estrogen content in the vaginal area. There's some other causes of UTIs, like people who develop stones in their bladder and so forth. But the treatment is, one, get rid of the current infection, and two, look at what might be the cause of a recurrent episode and try to prophylax or prevent future episodes of UTI. So, for example, if you have a young female, she's in her 30s and she comes in, she gets a UTI every time she has intercourse, we're going to treat the current infection and we're going to put her on a preventative antibiotic that she would have to take at the time of intercourse. In a perimenopausal female or postmenopausal female, the treatment is basically to restore the estrogen content. And that's easy. Topical estrogen is safe. A lot of women fear using estrogen, but if you use it at a skin level, in other words, around the urethra topically, it's very safe and it can prevent most infections.
So, Paul, the patients who have breast cancer, I know you mentioned estrogens, topical estrogens, but let's say that they're HER2 negative, H2 HER2 negative, estrogen binding positive. How you do that? I mean,
I tell them it's very safe to use topical estrogen because it gets into the tissue level. It does not get into the bloodstream.
Okay.
It doesn't interfere with their estrogen levels in the blood, and it's very safe. And there are a lot of positive things that can happen from estrogen using. They restore vaginal dryness, discomfort during intercourse, restores the bacterial content and the pH, prevents infection. So it's very safe, and women should take advantage of that.
Excellent. Appreciate that. Listen, guys, if you women and men have questions, I don't want to be the only one to ask questions, but if I have to, I'll ask them because I think you guys want to ask questions, but you're not doing it. So feel very comfortable in asking Dr. Khan questions.
Well, I'll bring up a quick question for you here.
There you go.
You mentioned the importance of treating hypertension.
Yes.
Do you know one of the commonest causes of ED, erectile dysfunction in my office, is the overtreatment of blood pressure? You have to have a certain blood pressure to be able to get blood flow to your penis.
It's true.
Now, you internists like to treat the blood pressure, and I get that. But I would say a good 80% of my guys that come in with ED are seeing me because of these blood pressure drugs. And I have that conversation with them all the time. I said, guys, look, you need to go talk to Dwight and tell Dwight he's off of the blood pressure pill. Listen, you got to live life, right? You can't lower a guy's blood pressure and then he can't have some fun.
Now, you know, what's funny is that I'm sure that Dr. Gavin is probably itching at the bit to say something about that because that's what he does. So, Dr. Gavin, one, I'm not an internist, I'm an ER doctor, emergency medicine and stuff, right? But I do see people in the ER and we do certain things with them. I don't see them typically in follow-up. But Dr. Gavin, you may make a comment, if you would, doctor, about
the
blood
point is
pressure.
really well taken. And in fact, one of the first things that we do is to say that we're going to try to make sure that we're giving you blood pressure medicines that will not interfere with vital processes that are important in your life, like sexual function. And by the same token, we want to make sure that you don't have other issues related to the medicines that we give you. And therefore, be on the alert. When you start taking this medication and you see changes in your ability to do certain kinds of things, for example, like to have appropriate erectile function, then you need to let us know. The thing is so that we can start explore other alternatives. And that's the thing that we have to do. We have to be on the same page. So it has to be a back and forth so that Dr. Khan doesn't have to be the one put on the spot and sending them back saying you need to fix this. So that's what we try to do.
And I know Dr. Khan, he will do that. Listen, let's back up for 1 second, if you don't mind, Dr. Khan. When mentioned about radical prostatectomies, if they have to have that and they get the erectile dysfunction, so on and so forth. Sometimes I guess the nerve is cut, what have you, that's going to that particular area. No one has talked about it yet, but I just want to just throw it out there about these injections, trimix, bimix, prostaglandin type injections. I know we're off away from this subject, but I wanted us to at least talk about that too, because sometimes men have studies, right, that have had radical prostatectomies, other things, right? But I tell them that when, at least my understanding is that, and I think I got that from you, Dr. Khan, is that when you inject the side of your penis with the prostaglandin and the other things that are in it, pretty much bypasses all of that and it rushes the blood down to that area. And it stays there for a couple of hours. You know, the only thing is that sometimes men that are older men, they can sometimes have heart attacks and strokes. But the bottom line is that they keep it moving, if you know what I mean. But go ahead, Paul, you say something about that.
Sure. So taking out the prostate doesn't always cause ED. When we do these surgeries, we try to do them by saving the nerves. That's called a nerve sparing prostatectomy. And those men typically after about 2 years will regain most of their sexual function. When the cancer is aggressive, we don't want to do nerve sparing surgery. We take the nerves. So we can pretty much tell the patient ahead of time, look, expect some recovery, or if I'm going to take the nerves, you're going to be impotent after your surgery. It doesn't matter. Everybody responds to these injections. They're easy to do, easy to learn. They're safe. They're not expensive. And typically, once that we've found the right dose for a patient, it'll give them an erection for about an hour that goes down after ejaculation. So I highly recommend it.
Yeah, I'm sorry, go ahead. Because someone had a question in the chat about getting, was that Chris?
I'm concerned about yeast infection after sexual.
She's concerned about yeast infection after sexual intercourse.
Okay.
That's a question.
Sure, we'll address that. So typically yeast infections come about, again, when there's disharmony in the pH of the vagina. Now, diabetic patients are prone to yeast infections, so they're going to get them. But women who also take antibiotics that disrupt the normal flora, they are prone to yeast infections. So typically there's always an explanation as to why a woman is getting recurrent yeast infections. It doesn't have anything to do with improper or poor cleanliness. You know, people are predisposed to yeast infections. So most of the times we can prevent them. So if a woman is getting it, you know, you have to look at the estrogen content down there, look at the pH of the vagina, see if she needs estrogen or more than estrogen. She might need progesterone as well. But there's always a reason for it.
You have another person coming through the chat again. Same person that said that she removed half her uterus.
Is that why?
Is that why she's having these, I guess, yeast infections?
Yes. She needs to go talk to her gynecologist about estrogen replacement. And again, topical is very safe. But that's a whole nother subject. These estrogens come in various forms, and not everybody's a good candidate for them.
Right. Now I'm going to talk on behalf of the fellows, because I know they want to ask this question. They haven't asked it yet, so I'm going to ask questions. And I'm not embarrassed to say that I went to your office once. I want to just check out a few things. They're a little older. I want to check out a few things. So I asked you about injections, right? I do all right, but you know, we want to get a little better. So I asked about injections, and we went over it in some details. You showed me how to inject. Like you did the first injection into the penis, which is was not an uncomfortable shot, a little pinch. very small needle. And after that, I got to tell you, I was kind of amazed actually. Within a matter of, I don't want to say maybe 5 or 10 minutes, it was back when I was more of a younger guy, I guess. That it was really pretty doggone good, and it lasts for a long time. My point is that, guys, is this: is that hearing Dr. Khan say that if you've had all these different surgeries done for your prostate, other prostate issues going on too, diabetes, what have you, even heart conditions, we talk about that, but cardiovascular disease, injecting that into your penis did just not interfere with your blood flow coming from your heart going down to the penis. Is that
You
correct?
brought up a great point there, Dwight.
Yeah.
People with cardiac conditions, people who are already taking a lot of blood pressure medications, people who are on nitrates for angina, should not be taking drugs like Viagra or Cialis. So those patients should be treated with and talked to about penile injection therapy. It's very safe. There's nothing bad that can come out of it.
Appreciate you saying that, because now it's going to be repeated. It's going to hit over and over again. I know that the lady's going to make sure that their husbands, if they're not on, if they listen to this recording, because there really is some things that we're concerned about. To let the men know that they can still do what they need to do to make mama happy, whatever it is, with these different injections. And the nice thing about you, Dr. Khan, is that you're really on top of this thing. And there's a mixture that I took initially. I took one that was not what I needed to have. I thought I wanted a little bit more, whatever it was. So you did a combination of things. What are in those injections, Dr. Khan?
So there are basically 3 drugs, and they all do the same thing. They open the blood vessels. They're very potent vasodilators. By opening the blood vessels, they cause increased blood flow to the penis. So there are 3 drugs that are in there. And when we use 2 of the 3, we call it bimix. When we use all 3, it's called trimix. And nowadays they have quadmix. Quadmix involves using a little atropine with the other 3. But there's prostaglandin, there's regitine, and the quadmix, which has the atropine in it. But they all do the same thing. They open the blood vessels and let a lot of blood flow into the penis.
Yeah, and I'd like to let people know also that they need to have something like Benadryl or something available, because sometimes you develop what we call priapism, and that's an uncomfortable situation. I've seen patients treated with that. I treated them in the ED, in the emergency department. And priapism, you may want to talk about that a little bit, Paul, and say some of the things that they may want to have available to them.
Sure.
They happen to be, erected in erection for more than 2.5, 3 hours. And we're talking about a pretty strong erection, by the way, guys.
Yeah.
Yeah.
So if the patients follow the instructions, that should not happen. We always start off with a very low dose, like you mentioned, and we gradually increase it to get it to where the patient and his wife are happy. Priapism comes about when people overdose. They want to use too much of it, or they inject themselves twice. So that's a prolonged erection, which is something that either brings the patient to the emergency room or back to the doctor's office to have another injection put in there to counteract the ones that were put in the first place.
Very good. I guess we can move on. We may be close to the end of this, but that's what we got, because I want to have some questions, and I want to force people to ask questions. Here we go. Urinary incontinence. This is another big one.
Okay. Urinary incontinence means leakage of urine, involuntary leakage. There are lots of kinds of incontinence. The most common is what we call stress incontinence, and that's when someone coughs or sneezes or laughs and they leak a small amount of urine. That happens to women more so than men, but it can be quite disturbing for patients. The treatment for that is to put a sling, which is a little surgical procedure, to tighten up the female urethra. We also use what we call bulking agents. These are agents that are injected around the urethra to tighten it up. Another common cause of incontinence is what we call urge incontinence. And that's when a patient gets a strong urge to void and they cannot control it. The other name for that is overactive bladder. Typically, these are, well, men and women, diabetics, people who have had radiation for different cancers in the pelvis. And the treatment for the urge incontinence is medication. Medicines that relax the bladder musculature, like Gemteser and Myrbetriq. Another type of incontinence is what you call enuresis. These are people that wet their beds at night. They're dry during the day, but they get bedwetting. And there are drugs for that. Desmopressin, I'm sure you heard of that, is a drug used for enuresis. And then kids get a whole different varieties of incontinence, but most of those have to do with bowel changes as they're growing up. We won't get into that. So how do you diagnose it? It's basically by taking a good history. You ask the patient, do you leak when you cough, sneeze, or laugh? Do you have urgency where you have to hurry to the bathroom and you can't control it? So it's easy to make it just on the history. Now, a lot of times when we examine our female patients who present with this, we find that they have pelvic floor dysfunction. They have pelvic prolapse. They have cystoceles. They have rectoceles. So everybody needs to be examined and assessed properly because some of those patients require further surgery to treat their prolapse. Any questions on that?
Yeah.
Chris had a question. Wife had a question. I think she's still scheduled to get in to see you sometime, Paul, and hopefully in the near future.
Doctor,
Yes.
so how long is if you have surgery, how long is the post-op?
So it depends on the surgery. If you're having a sling put in because you are leaking when you cough or sneeze, those are outpatient procedures. You go home right after, and the recovery is quick. On the other hand, if you have pelvic prolapse and there's a prolapsed bladder or uterus, those are bigger surgeries, and typically, 3 to 4 weeks, like any major surgery.
So if you put in a sling,
Yeah,
how
sling.
long am I out for exercise?
You would be out for exercise for about 3 to 4 weeks.
And how long is the procedure?
About 15, 20 minutes. It's
Wow.
actually done by making a small incision in the vagina, right underneath the urethra, and the sling is inserted through a very tiny incision.
And is that something that typically is covered by insurance companies or?
Yes, it is. But that's for stress incontinence.
Right.
Urge incontinence, on the other hand, no surgery. Medications work well.
And may I ask, what is the typical cost? I'm just curious. If someone had to pay cash, I'm just curious. What is the typical cost for them?
For a sling,
Yes.
I think probably about $3,000–4,000.
And
But that would include the anesthesia, the outpatient surgery
right.
fee, and the cost of the device.
Got it.
What is that made out of?
It's made out of a material called polypropylene.
Are there any reactions to that in terms of people that do not?
Yeah, if it's not put in correctly, you can end up with a host of problems, like not being able to pee, or it could put a lot of pressure and erode through the urethra into the bladder. It can cause painful intercourse if it's not put in right.
So let me ask you the next obvious question then. I ask people that have any questions that do cosmetic surgery too. How many have you done? What kind of complications have you had? If any?
Over the years, I've done a lot of these surgeries. I hopefully don't see too many complications because, once you've done a lot, you know what not to do, what to do.
I
So
have a
they're very
question
well
about,
tolerated.
I have a question. If you take medication, what is the side effect?
Dry mouth is a common side effect, but the newer medications that we're using nowadays, they have no side effects like Myrbetriq or Gemtesa. The problem with those drugs is they're new and they're a little bit expensive. And a lot of the insurance companies don't want to provide them to patients. They want you to use a cheaper or a generic drug. But the newer class of drugs are very well tolerated.
Thank you.
Very good
Very
question.
good question.
Okay, so you're gonna have a question, you can ask questions after this is done. I have a couple of announcements to make. One, those that are on the webinar and they're still joining, by the way, and I know that would happen. We just finished the event here at a major church, Baptist Church in Miami Gardens, just at 12 noon. So unfortunately, people's gonna come on and they'll be able to get this later. But our next event will be at new Shiloh Baptist Church, Baptist Church in Miami Gardens, Miami, Florida. And that's going to be from 9 a.m. to 1 p.m. Again, that's on January 25th, 2025. The next webinar will be February 22nd, 2025. We'll be talking about cardiovascular disease, early detection and treatment. We'll also be talking about colon cancer at that time. So, but anytime you guys have any suggestions and or questions, you can put it in the chat box or just respond to me on my email so I can talk to you directly. Dr. Khan has been, Dr. Khan, thank you so much for coming on. You've done a super
Absolutely my pleasure, Dwight. Thanks for having me.
sure and explaining things. And I'm not sure how, I know you're very busy, very booked up, but hopefully on some of these patients will have, will make requests, I'm sure of that, especially the husbands. Because when they understand that prostate cancer, that's not always a surgical procedure for them, and it's a low grade, then it's always encouraging to someone to give them at least some encouraging news, right? The other thing regarding the incontinence issue, something that takes about 15 minutes to do, and they may be down from exercise for 3 or 4 weeks, like you said. I think it's pretty great that they would be able to get away from those depends and those different things that are embarrassing ladies. And, also they have issues when they're, I'm sure when they're performing custodial duties, put it that way, with their husbands and their significant other. So I think that's a really, really, really good thing for them to want to come in and see you. And I always ask about how many have you done? You said a lot. I usually have a little comeback on a lot. Well, I'm a doc. I ask you, well, what does a lot mean? Have you done thousands of these procedures? 500? How many have you done?
Incontinence surgeries?
Yeah.
I would say thousands.
Okay, thousands. That's good. Yeah, because again, when you say a lot, I'm that kind of guy. You know me. I'm what does that mean? A lot, or I've done a few. Whatever it is. So yeah. So you done a few thousand of these things. Yeah. So you've never had any significant complications.
No, not major.
Right. And the people, I guess they must be happy because when they're able to get rid of that incontinency problem, and a lot of women are extremely, probably more so than men, they're more sensitive to they're more concerned about having those kind of leaky issues, so to speak. If they can get rid of that in a matter of 15 minutes and there's really no significant downtime, I like that idea because I see a lot of women, I talk to a lot of ladies, Christine does, the wife does too, that have these issues. And I think they've been told about a Marshall machete, a different type of major type of a surgical procedure that used to be like this done back in the day. You can tell them what a Marshall machete is, but that, to me, I think that's a major lifting. And
yeah, that's not something we do much anymore.
Right.
The newer modern operations are all intravaginal through very small incisions.
Yeah. And then, and for older ladies that are on, let's say older, any of the woman that's over 60 plus years old, they may know about the more aggressive procedure, how it used to be done. They're not necessarily up to date on what's being done now and how it's done. So I really appreciate that. If you guys have no further questions, I guess we can end our webinar for now. And we'll be able to, if you want to request Dr. Khan's information, sure that he'll be happy to entertain that. You go to his office, but we'll work through a process for that. But I really can't thank Dr. Khan for participating in our webinar. This will not be the last time it'll be on, so we'll get a chance to know him pretty well.
Thank you, Dwight.
Yeah, thank you so much. Are there any other questions? Yes, this question to me, it looks like.
Vagina, but and to know.
General, okay. Here's a question that came up. I think I see it here too. This person, I'm not sure who it is, but she says that I have a vagina. Okay, I'm glad to hear that. Hold on.
But I'm using.
Here it is. But she's using, apparently she says I'm using, she said LOL, she has a vagina, okay, LOL. I'm using a Tylenol, chlorthalidone, which is my favorite combination, 50-25, which is good. And it lowers my blood pressure and glucose levels. Is that normal? I guess, Dr. Gavin, I can talk about the blood pressure, that part is normal, but does it normally lower your glucose levels?
No, as a matter of fact, I did address this question in the chat box
Oh,
that
did you? Okay.
you expect the blood pressure to be lowered by this combination because it's a good one. It's the diuretic and a beta blocker, but it is highly unusual for that kind of combination to lower your blood glucose. So it would be important to know what other conditions she might have, what other medications she's on that could help explain why the blood glucose is going down. That would take a little bit more digging because how much does it go down, under what circumstances relative to the timing of the dosing of the medication that you're on now, that would have to be taken into consideration. But it's unusual for that to affect your blood pressure, blood glucose by lowering it. Typically, you'd expect it to, if anything, cause it to rise a bit.
All right, everybody have a great weekend and enjoy the games, as I will later on today. Be blessed.